Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care. Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm your host, Gavin Ward, for today's episode. In today's episode, I sat down with DispatchHealth's co-founder, Kevin Riddleberger. Kevin shares his story of becoming a physician assistant at a younger age in life and how he eventually wanted to do more and started DispatchHealth in 2013, which recently expanded to its, I believe, 17th state and is now in 33 locations. And they continue to grow with 1 to 2 markets opening each month. And at the end of the episode, for our California listeners, you'll hear a little bit of a hint of maybe some things to come in the West Coast as they further expand in the future. We hope you enjoyed today's episode where Kevin talks about how they're bringing the ER to the home, but not just the ER to the home, but also maybe skilled nursing to the home or instead of a skilled nursing facility stay. So again, we hope you enjoyed today's episodes. Feel free to check us out on other episodes of Pop Health Podcast by visiting us on pophealthpodcast.com, our YouTube channel, Spotify, Stitcher, Apple Podcasts, and wherever you listen to your shows. Thanks, everybody. Enjoy the show. Well, Kevin, thank you so much for joining the show today.
Thanks for having me. Really looking forward to the discussion.
Absolutely. So we like to start off the show, Kevin, by getting to know the guests. And for audience, for you out there, I actually joked with Kevin. I, growing up, got called Kevin quite a bit because Gavins weren't a common name like they are today. So Kevin, what's something about you that might surprise the audience? Maybe something outside of the healthcare world?
Oh, something surprising. Life outside of the healthcare world is busy with family. So, really enjoy with going up to the mountains, living in Boulder, Colorado. So go up to the mountains and have a lot of fun with the family, ski in the wintertime and do some outdoor activities in the summertime. So that's where you'll, find me, outside of DispatchHealth.
Okay, cool. So you're in Boulder, Colorado. I've heard Boulder, Colorado as a whole has definitely grown quite a bit over the last few years. Has Boulder been one of those cities in Colorado that's just blossomed? Is traffic getting worse?
Yeah, Boulder's not, still has some room for growth when you compare it to the Denver area. But, with University of Colorado area, a lot of tech, companies are moving into town. Google now has, probably 150,000 square feet, of office space, in downtown Boulder. It's a small little tech, community. Okay. It's a startup, world as well. My wife grew up, born and raised in Boulder. And so we spent a lot of time in the area and enjoy what Boulder has to offer.
Awesome. Well, lucky her. She gets to live her adult life in her hometown. I don't believe Boulder, Colorado is your hometown. Tell us kind of where you grew up and that story.
Yeah, I grew up in upstate New York, about an hour south of Syracuse, in the Ithaca, Binghamton area, if you know the Finger Lake, district. So went to school in undergrad in northern New York, just all, Canada. And, after that really started to make my way out west. Attended grad school in the Chicago area where I got my PA training. It's where I met my wife, who is also a PA, and she wanted to live nowhere else besides Boulder. So we came back to Boulder, and that's where I started my professional career as a PA in Boulder. But love upstate New York. Still have a lot of family back in the area, but also love being in Colorado now.
Awesome. I noticed the folks that I've met from New York, if you're not from like New York City, usually an accent doesn't exist. And I noticed you mentioned you're from upstate New York, and there's not really that, tough New Yorker accent there.
Yeah, there is an accent in upstate New York, and so I can, it's not the Long Island, New York City accent, but there's a distinct, accent for upstate New York folks. That I can pick out if someone that I'm talking to, I can, usually pick up on.
Okay. All right. Well, thank you for the education. I'll have to learn how to pick up on that. So you mentioned you came out west. Your wife is from Boulder, Colorado. So you go to school, you're a PA, you start doing physician assistant work. At what point did you want to do more or thought about maybe being an entrepreneur?
Yeah, it was in the middle of my career where, and this was in the 2003, 2004, 2005, so a while ago, where EMRs at the time were just starting to come. And I was on the hospitals I was on staff at were deploying the Epic systems, the McKesson system. So I was on the deployment committees around that. Also gotten involved in process improvement, quality improvements at the hospitals I was on staff at, and really started to learn and was very intrigued on all the pieces and how they work together. Meaning, how does a consumer access healthcare? How do we get paid for the service we're delivering to our patients? And then from a clinician, how do we make our jobs easier? How do we drive the best clinical outcomes for our patients? How do we deliver those results to our payer partners as well? And that I really was intrigued on what else could I do outside treating patients every day. And went back to business school at that time to really learn the intricacies of business and how it really applied, to healthcare specifically.
Okay, cool. So when did DispatchHealth, come together, and how?
Yeah, it was. I had left clinical practice, joined a startup called iTriage back in the day, and this 2011, 2012, where that company was a consumer-facing mobile app company that was directing people to the appropriate level of care based on their symptoms. So, you had, downloaded the iTriage app, entered a cough into your symptoms, you would be presented with follow-up questions to direct you to, do I need to go to the ER? Do I need to go to the urgent care? Should I schedule an appointment with my primary care physician? That's really, that got me to start around the technology involvement to guide consumer behavior and direction. My other co-founder, Mark Prather, who is an ER doc, had joined iTriage as well. We got talking about what if we deliver a step to this, where we guide people on their clinical symptoms. Could we actually deploy a medical team to be able to take care of those patients in their home versus them having to seek out that care, whether it be in a facility or into their primary care physician? And in 2013, we had an opportunity to partner with an EMS agency that was looking at community paramedicine. Yeah. How can we take the 17% of patients that dial 911 that really don't need to be transported to the emergency department? And so take a different spin at this by putting a ER-trained nurse practitioner or PA in those ambulances to be deployed out to take care of them in the home versus them actually being sent, to the emergency department. So we studied that model for about 18 months, really under the radar, bootstrapping the whole operation to say, are we making an impact on the patient, our patients wanting to receive care inside the home? What clinical outcomes or what clinical capabilities could we bring into the home safely? And lastly, are we actually driving costs down in the system, or are we just adding agency? And what we found is that patients loved receiving the care in we were able to really package up a mini ER into these vehicles to be able to take care of these patients, safely inside the home. And then outcomes, we were able to drive, down the return to the ER a considerable amount, meaning we were making sure that we were connecting those patients back into the continuum, be a home health agency, whether it be their primary care physician, a care management, group, to make sure that they were getting back on the right path to recovery. And so that's really the foundation where everything was built off of. Expanded in 2015 in the Denver market.
So when 2013, when you're putting together your ideas, you mentioned bootstrapping. So at the time, were you not receiving any fees for your service or for those first 18 months, or how did you guys, sustain yourselves, I guess?
Yeah, we were not for a period of time. Once we were able to start collecting data based on the outcomes that we were able to achieve, we were able to go back to the payer community and determine this data based on clinical outcomes, based on cost savings, and say, hey, I think we have an opportunity to drive further savings for you all if we're able to get paid. And so we started to develop a contract with Medicare Advantage plans, commercial plans here in Colorado, became Medicare providers, Medicaid providers, and uncovered codes that were available for us to get paid by Medicare and Medicaid as well for care delivery in the home.
Okay, nice. So today, you mentioned, originally it was the Medicare Advantage plans, commercial plans, and then also you mentioned the codes for Medicare and Medicaid. So today, can folks, whether they're part of a Medicare Advantage plan, a commercial plan, a Medicaid member or a Medicare member, potentially use your services if they're in the geography you serve?
That's right. So we contract for all business, from managed Medicaid to commercial to Medicare Advantage plans, and on the commercial employer-sponsored, plans that are out there, and we work with 300 plus, over the country, across the country. National arrangements, with United Healthcare, Humana, and many others for all lines of business for the care that we're delivering, inside the home. And I think the last statistic that I saw was just under 2 million lives, across the country are contracted, for DIS services.
Okay, awesome. So let's talk a little bit about two things. I mentioned geography a moment ago. Can you share with the audience where are you guys today and where are you guys tomorrow?
Yeah, currently we're operating in 34 different markets or MSAs across the country. And so one market would be, where you live in the Phoenix, area. So we'll cover from to the East Valley. And so that's one market for us. So there's 34 across the country. We're in now 18 states. We'll do about 350,000 visits this year across the country, delivering ER level care inside the home.
Okay, so you mentioned ER level of care. What about your services might be different than an ER? Is it pretty much anything an ER can do, or are there limitations?
Yeah, there is limitations as to what we're able to bring into the home, and we don't ever want to say that we're going to completely substitute an ER. But look at the data. About 60% of what's in the ER today could be treated in a lower cost setting.
Okay.
And so every patient that comes into DispatchHealth, we want to risk stratify to be able to determine, are we clinically appropriate to send out a medical team in a timely way, or do they need a higher level of care, such as the emergency room? And so when patients call us or clinical partners call us or request care online or through a mobile app, they'll get on the phone with one of our care team agents to be able to go through our technology platform based on patient symptoms will address follow-up questions and are we clinically appropriate? If it's deemed clinically appropriate, we'll then sign a medical team to be able to go out and treat them inside the home. Inside that vehicle that comes out into the home is a moderately complex lab. So being able to get point of care lab testing, the ability to be able to deliver IV medications if need be. Needed to suture up a laceration, you can suture up a laceration. Cauterize or pack a nosebleed, able to do that. We bring a 12 EKG, with us if patients, we need to further assess their cardiac stance. If we need to provide NEB treatments on these patients. So a wide range of clinical capabilities that we're able to package up inside of our vehicle in about 7 big suitcases, able to take care of these patients, safely in the home. And the last thing around the clinical equipment, it's not a single individual that gets deployed. It's really a team that's taking care of this patient. So 2 individuals in our vehicles at all time, an ER trained nurse practitioner or PA, along with a medical technician. And then they are supported by a virtual ER physician that's available to be able to talk to the patient if need be, or our nurse practitioner or PA could contact him to be able to review those clinical cases if need be.
Okay, awesome. So this ED physician is on video or can at least see the patient if need be, like a consult basically, or how does that work in the home?
Yeah, it is, right now with our NPPA being able to, talk through the case if need be. So, they're able to present, this to the ER physician if need be. But the ER trained nurse practitioner PA, very capable to be able to make those independent clinical decisions and drive a treatment plan, on scene for those patients. And the ER doc is available if need be.
Okay, cool. So the response time. So if I call in as a patient or you have a case manager calling on my behalf and you guys decide, yes, we can treat this, what's the goal with the turnaround time?
Yeah, we try to shoot between 2 to 3 hours that we arrive on scene on average. And so that's from the time that you request care to the time that team shows up on scene and takes care of that patient.
Okay. And then the financial side of things. So, my daughter went to the ER recently. Everything's good. She's fine. And we have great insurance. My wife's a teacher. She has this fantastic, PPO plan because the union negotiated a pretty dang good package. But our co-insurance or cost was still like $1,000 for our ED visit. How does it work with you guys?
We again contract with those payers. We are on the benefit side of things on the back end. It will hit really your urgent care benefits. Okay. And so based on your out-of-pocket copay, for urgent care, that's what you would expect, to pay, for a DispatchHealth service. So there may be some high deductible plans, based on where you are with that. But on average, it hits your urgent care copay.
Okay, awesome. And then what about hours of operation, Kevin? Like, when are you guys available?
So we open at 8 a.m. And operate through 10 p.m. 7 days a week, 365 days a year. So every holiday we're open, and vehicles, based on the market maturity, you may have market or Las Vegas market where we'll have close to 30 vehicles operating in a given market per day. To newer markets that we had just opened, start off with 2 vehicles. Yeah. And as we continue to expand and create more awareness around the service, we continue to add more vehicles to be able to service those patients. Okay, great. Let me ask you this. And don't mean to be a loaded question, but at the beginning, when you're, starting up this organization and you're taking away business
from hospitals or urgent cares. Was there some pushback in the communities? Even today, is there any pushback when you guys are coming in? And it seems like it's the right thing to do, but you're also kind of taking away some of these profit centers. Curious your lens there.
Yeah, and so when it's a new program, a new option, for patients and clinical partners, and just to dig into that a little bit further, over the years, we've been able to establish fantastic relationships with provider groups, fantastic relationships with health systems, across the country. And these are systems that are ways to be able to meet the need for the healthcare consumer. Healthcare consumers are really looking at options, just like in everyday life. Their Amazon, packages get, sent, they order and get sent and received within 24 hours, 48 hours. They want to have that same experience for healthcare. I mean, you've seen this rise in virtual care. We've been able to meet that consumer demand, delivering this high touch service to patients and deliver that care inside the comfort of their home. Now, over this time, we've had to make sure that we align very well with primary care groups and health systems. Health systems are looking to take on value-based care, and this is a perfect, for them to be able to look at ways to be able to decrease, costs, within the system. And so we align very well with them. We also align around opportunities to have cost option to provide greater access to these populations. So, it's very expensive to put more beds, hospital beds, very expensive to put facilities up, as markets continue to grow. So we're a very flexible option, for these provider groups, payers, as well as health systems, to be able to take care of these patients and collaborate on managing these patients. We're not going to do everything. We don't manage longitudinal patients, for their primary care conditions or chronic care, conditions. But we're an adjunct, to primary care, where these individuals may need, a rescue to be able to go out into the home and take care of them and report primary care physician, where they're able to maintain that continuity. And so we are really a new tool that a lot of these care management groups, home health agencies, primary care groups can deploy to take care of these patients effectively in their homes.
Thank you, Kevin. So transitioning over to kind of the phrases that we're hearing a lot here in the post-acute world is Sniff at home, or skilled nursing facility at home, hospital at home. We've talked a lot about how you're kind of like an ED or emergency department at home. Tell us about this Sniff at home or skilled nursing at home and where you fit there.
Yeah, and I much about the evolution of the organization over time. So where we started in the EMS space, in the pre-hospital space, to be able to intervene on acute clinical conditions to avoid unnecessary trips to the emergency department, over time, we've expanded, on clinical capabilities, inside of the home. In 2017, with a couple of health system partnerships, we identified an opportunity to help transition patients that were coming out of the hospital that had a greater risk of readmission within 30, 60, 90 days. And so we built a program called Bridge Care, where we work with home health agencies and primary care groups, as well as case management in the inpatient setting, to meet our service 24 to 72 hours after they come out of the hospital. Very similar to a transitional care visit inside of a primary care physician. We're able to meet the where the patient's at inside their home and help bridge them back into the primary care physician. So that's something we continue to operate and have expanded a great deal over the last few years with health system partners as well as payer partners. In 2018, talking about the Sniff at home and hospital at home, we built out and used really 2018 and 2019 to build out that hospital at home program, Sniff at home program. So in Denver, in November 2019, we launched really that first program where we could identify patients that meet hospital level criteria inside of the community and admit them into the home setting. So practically how that would work and how you would compare it to traditional healthcare is that instead of showing up into the ER and being sent upstairs for admission, that ER level of care meets the patient inside the home. We identify that they need a higher level of care, and we wrap in our hospitalist team to take over that care, just like that patient would be sent upstairs inside of a brick and mortar, setting. We would take over that care, admit them into the home setting, and take care of them for 2 to 5 days, just like in an inpatient setting, and then transition them over the course of 30 days in a post-acute setting inside the home. So that's something we launched in November 2019, are now expanding that into 6 additional markets at the second half of 2021, this year, to be able to deliver that level of care. And so the vision and the ultimate goal of what we're building is a system inside the home. So if you think about ER level of care to transitional care out of the hospital to Sniff and hospital level of care inside the home. So building that system of capabilities to be able to treat these patients and avoid expensive ERs, expensive hospitals, expensive SNFs, when need be, and meeting that consumer demand of staying in the home and aging in place.
So for the Sniff at home model, when I think of Sniff, I think of, I'm in a facility, a nurse or a nurse comes, checks on me a few times a day. So for your model, are they being seen in person a few times a day or virtually? How does that work?
Yeah, so the Sniff at home and advanced care or hospital home programs really act, it's the same group, taking care of those patients. So it's our hospitalist group, and they flex in the intensity of different services that are needed, based on the needs of the patient. So we still, on our hospital home program, advanced care will have daily rounding by that hospitalist group inside the home, supplemented by twice a day nursing care. And so that individual will, just like in the inpatient setting, will have physician rounding and driving that care plan. And then we'll also have nursing support, care. They will also have remote patient monitoring. So at all times, we will be tracking their vital signs throughout the day. And then they have an alert system where they can always, just like in the inpatient setting, a call button. We have a call button as well that we can immediately get in the phone, with that patient to understand what's going on, with them if need be. At home, it's really more intensely driven, care with oversight of our hospitalist group to manage that care plan. And so there's inpatient or person visits that we do with that model, but more intense on the physical therapy, occupational therapy, nursing for Sniff level of care.
Okay, got it. And then for the nursing care, are those like dispatch employees, or do you contract with partners who are your nursing team? How does that work?
Yeah, it's a great question. So we, in going back in terms of our clinical model in general, we employ all of our clinicians at DispatchHealth. So we now have close to 700 clinicians across the country delivering, this care across, our ER, Sniff, Bridge, and advanced care. On the nursing side, we do for our hospital home and Sniff at home programs, advanced care and extended care, we subcontract out nursing, services. So we work with and build a network of clinicians and services, not only nursing, but DME, imaging, pharmacy. We'll create that network, and we get paid a bundled, rate for the care that we're delivering, and subcontract again and pay out to those entities. Okay,
got it. So just to confirm, like with the Sniff at home model, your And if a non-healthcare person is watching or listening, the plan or your insurance company would either pay you guys a bundle or another entity would pay you guys a bundle to manage that care for the Sniff at home model at an equal to or lower cost than a traditional Sniff, I would assume, right? Like that's the goal.
That's right. That's right.
Okay, cool. Yep. Awesome stuff. And I appreciate your transparency on some of these questions, Kevin. So today, 700 clinicians. Earlier in the episode, I wanted to go back to a question I had, which was about where you guys will be tomorrow. So we know where you are today. What's your vision, or are you able to share anything that's coming down the pipeline with expansion?
Yeah, we're now on track to, open 1 to 2 markets every month.
Every month.
And so the market expansion, just continues. And so, by the end of this year, I believe we're on track to be at 44 markets by the end of 2021. Now, not only is it, going wide, based on market expansion, but it's also going, deeper, on some of the services that we deliver, in the existing markets. And so we really start off with that ER level of care, inside the home, and then start to add additional services on top of that. So you think about the bridge, care services. You take the, hospital at home or advanced care services, Sniff at home, extended care services. And so that's really building out, that ecosystem, that system of care inside the home in these given markets. And so that's where you'll also continue to see growth and expansion in the existing, just going, deeper on the value prop, going deeper on the clinical services being delivered inside the home.
Wow, man. 1 to 2 a month is pretty incredible. If you mind me asking, one thing, sometimes I get into it, sometimes I don't on our episodes, but the financial side of thing for you guys, you mentioned like 2 cars per market, which is expensive, right? You got to have the vehicles, you got to have the staff. You start with 0 business in every market, but maybe some contracts. How is this gigantic growth happening? Are there financial backers behind the scenes? How's that working?
Yeah, it's, we've recently closed on a Series D round of funding. The last round was about $200 million in what we raised at that time. And it's not only the financial backing of the company to continue to help us grow, but it's also, great alignment with health systems as well as our payer partners, whether it be United Healthcare, where they're really moving fast on the thesis of more care in the home. And so we're aligning, very well with them. There's a lot of movement, as you know, in the space on care delivery in the home. And we want to be right there as an option to be able to continue to expand. So yes, the funding, definitely helps, but it's also continue to drive value for these partners to help stay focused on the quadruple aim. And so this is what we preach, every day here at Dispatch, whether it be our software development team or clinicians or our marketing team. It's how do we drive a fantastic patient experience from the time that they request care to we submit a claim for the services that we deliver. How do we drive amazing clinical outcomes, which results in improved cost reduction moving forward? And then how do we deliver a experience for our providers? We have 700 of them. We want to make sure that they're practicing at the top of their license. They have an effortless, experience of delivering this care inside the home. We want to make sure that we're, aligned with our clinical partners, with primary care groups, health systems, home health agencies, care management, groups that were, focused on those partnerships, because we can't do it, alone. We need all of us together to be able to drive, great outcomes for these patients. So So that's something we're continuing to focus on, to deliver on in all the markets that we operate in.
I'm really glad you mentioned the quadruple aim, not the triple aim, which triple aim was great as well. I was talking with a healthcare leader the other day, and she was talking about the outcomes, the patient experience, and the cost savings. Which is the original triple aim. And for the healthcare veterans that are listening in, you're probably familiar with this. But what's relatively new, and I love that Kevin mentioned it, was the quadruple aim. And just want to highlight there, it's his own staff experience. And you mentioned like an effortless experience as well, which is pretty neat. And my day job is doing the same thing. So for those of you out there, to me, the great companies are doing that quadruple aim and making sure they have that staff satisfaction and positive experience. So Kevin, I just want to applaud you and again, audience, hear that term quadruple aim. So as we wrap up today's show, Kevin, I always like to hear a story from our guests. And I want to ask you, can you share with us maybe a story that you've seen during your time at Dispatch that kind of really tells the Dispatch story and why you're there today?
Yeah, I mean, there's, now, over 200,000, patient reviews with a net promoter score of 95. That's been consistent, over the years. We hear patient stories all the time. And, whether it be, the convenience of being able to, be out into the home with a busy mom and to be able to, sew up a kid's laceration, on the kitchen table, is always great. To, being able to intervene on a 80-year-old who is trying to, age in place, inside the home and keep them there. But, some of these and the more impactful stories is really less on the clinical, pieces, but more on some of the social components that we see, inside the home. And I'm sure, your organization, sees this all the time as well. But these individuals that the reason why they're continuing to need acute intervention is some of the social components, whether it be, in their lives of hey, not, having the ability to pay for their medications because they need to pay for their electricity, or, not having, food in the fridge and our staff going in and actually cooking, inside of their kitchen, with a can of soup and delivering that for these patients, or, working with Feeding America and delivering, bags of food, for patients that we identify that have food insecurity. So these are the things that are really moving the needle around, clinical outcomes, and really start to what we call the Dispatch way, is going the extra mile internally around some of these other pieces, connect the dots when we see that there's a need for these patients, whether it be unable to, get any transportation, needs, or there's a fall risk that we identify, or there's a food insecurity or inability to pay for the meds. How do we connect them, with resources available? Or there's many instances where there's times where, we'll pitch in and say, thing that we could do to help out, and going above and beyond with the framework of keeping the patient centered around clinical outcomes and driving a great, patient experience.
Awesome, Kevin. Well, I very much appreciate all of your time, and also just a shout out to Kirsten and Raquel on your communications team for putting this together. And I know you're a busy man, so we appreciate you making the time to record today. If folks want to follow Dispatch and stay up to speed as to what you guys are all doing, what's the best way to do that?
DispatchHealth.com is probably the best way for us to be able to see some of the market expansions as well as expanding on our clinical services that we deliver inside the home.
So Kevin, earlier you talked about your expansion. You're going into 1 to 2 markets. So a lot of our listeners are actually in the state of California. And I know you're not here yet, but can you tell us, is that something, that you're looking at, maybe something in the future?
Yeah, obviously the state of California is a large market, and something that's been on our radar for a long time. And there's great opportunities for us to expand in the California market. So more to come on that, but it's definitely on our short list of market expansions as we close out 2021 and head into 2022.
All right, awesome. I definitely look forward to potentially using you guys myself in the future versus those long ED waits and bills. So, folks, Kevin Riddleberger has been our guest today, the New Yorker, now Colorado guy.
No, I really appreciate the time with you, Gavin, today. It's been a lot of fun. Always love to talk about the Dispatch Health story, and hopefully we'll be able to further align in the state of California soon.
Thanks everyone for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.